Okay, so thank you so much again, Daryl, and all of you. It's a pleasure for me to be with you. So despite major advances in treatment and prevention, the HIV pandemic continues to pose a major global public health challenge. And by the end of 2021, about 38 million people were living with HIV worldwide, with estimated 650,000 deaths and 1.5 million new infections in that year. By the second quarter of 2022, 2.2 million people had initiated oral PrEP worldwide. The US, South Africa, and Kenya were the top 3 countries in PrEP initiations. However, the goal by 2020 was to reach 3 million people. Despite evidence of impact on incidence in some settings and populations, we are still far from the global goal. There continue to be sustained gaps in the availability of PrEP, and the total number of people using this prevention option in 2020 was just 28% of the target 3 million in low and middle income countries, which represents only 8% of the new global target for 2025. Although PrEP is not meant to be a lifelong requirement, high adherence is needed during periods of use when an individual is at risk of HIV, what may be quite challenging to achieve, especially among the most vulnerable populations. To realize PrEP's benefits, individuals need to both initiate PrEP and remain on PrEP during periods at risk. In multiple studies, reasons for stopping or never initiating PrEP include, in addition to challenges assessing the medication, low self-perceived risk, concerns about medication side effects, or a desire not to take a daily pill, stigma, or competing life events, among many others. As such, daily oral PrEP is not feasible for everyone, and there is no single solution to address the HIV epidemic. Long-acting PrEP agents have the potential to address some of these concerns by providing consistent protection through infrequent discrete administration, avoiding the need to take a daily or on-demand oral medication. A number of long-acting drug delivery platforms are under investigation for HIV prevention. I will focus on the remaining of this presentation on long-acting cabotegravir, which efficacy was evaluated in 2 large randomized controlled trials, HPTN-083 and HPTN-084. So we will start with HPTN-083. In HPTN-083, we compared a PrEP regimen containing long-acting injectable cap to daily oral TDF-FTC for HIV prevention. It was a phase 2B pre-randomized double-blind, double-dummy clinical trial conducted at 43 clinical sites in North and South America, Asia, and Africa. The study enrolled cisgender men and transgender women who have sex with men, ages 18 and above, at elevated risk for HIV infection. Planned enrollment was 5,000 participants, and pre-specified key population metrics included that at least 50% of participants will be under age of 30, at least 10% would be trans women, and at a minimum, 50% of the US enrollment would be Black African American. And as I said, we had 43 sites, and they were in US, Argentina, Brazil, Peru, Thailand, Vietnam, and South Africa. Overall, 4,566 participants were enrolled. We surpassed the metrics for trans women and had 12.5% trans women enrolled, and they were assigned to cabotegravir given every 8 weeks, or daily oral TDF-FTC, as the study design that we are showing in this slide. The blinded portion of the study was stopped early for efficacy, with injectable cabotegravir demonstrating superiority over TDF-FTC with a hazard ratio of 0.34 for HIV incidence when compared to TDF-FTC. When examining subgroups, the magnitude and direction of the effectiveness of CAB was preserved among populations who have historically experienced greater adherence challenges with TDF-FTC PrEP as those that we included in the specific metrics, the youth, trans women, and US Black participants. The study continues now in an open label fashion extension that will be a 96-week open label in which participants without contraindication could elect to use injectable CAB or complete their study participation with daily oral TDF-FTC. When the blinded and the unblinded period are combined in the post-hoc analysis, we find a remarkably consistent hazard ratio of 0.34 that persists. The incidence rate in both arms now are more than 1.5 times higher in the unblinded period compared to the blinded period. Very importantly, no safety concerns were identified during the one-year unblinded analysis period. In interrogating this incidence rate in both arms being higher in the unblinded periods than in the blinded period, we found that study product adherence declined in both arms. In the TDF-FTC arm, sentinel adherence cohort using TDF-FTC in blood, TDF diphosphate in blood spots, we view a decrease in the proportion of samples, suggesting dosing consistent with 4 or more doses per week, an average from the primary blinded period, 73%, to the one-year unblinded period to 59%. And similarly, it happened with plasma tenofovir concentrations that similarly decreased in the unblinded period. When we look at the CAB arm, the injection cover declined from 91.5 during the blinded study period to 79.9 during the year one unblinded period. These declines in adherence were to be expected to produce approximately 40% of the absorbed increase in incidence. This remaining 60% may be largely, if not entirely, explained by the increased contribution of person years in the year one unblinded period from our Latin American sites with known higher background incidence. They initiated the study later than the US sites and therefore contributed fewer person years to the blinded analysis period, but the majority of person years in the year one unblinded analysis. Now, moving to HPTN 084 is a sister study similarly designed, but for the population of cisgender women in Eastern and Southern Africa that used a superiority study design. Overall, 3,223 cis women were enrolled, with 57% of participants aged 18 to 25 years of age. Women were excluded if they were currently pregnant or breastfeeding, and all women of childbearing potential were required to use an effective form of modern contraception with a failure rate of less than 1% with perfect use. Of the 38 infections occurring in the study, only 4 of them occurred in the CAB arm, providing a hazard ratio of 0.12 for HIV infection compared to TDF-FTC, demonstrating high superiority of CAB compared to TDF-FTC. There were no differences in treatment effect among the younger participants. The superiority of CAB is sustained when combining the blinded and unblinded period until December 2021 with a hazard ratio of 0.11. And this is just amazing. Overall, 132 pregnancies occurred during HPTN 084. They were balanced between study arms, and there were no apparent differences on pregnancy outcomes between study arms. Low adherence was extremely common among HPTN 084 study participants on the TDF-FTC arm, with only 3% of these participants having levels suggesting a daily use of TDF-FTC, again using dry blood spots. So the most commonly reported side effects were injection site reactions with decreased in frequency and severity over time. In 083, only 2.2% of participants in the CAB arm discontinued due to an injection site reaction. 80% reported pain or tenderness at the injection site in the CAB arm, compared with only 31% of those in the TDF-FTC arm who received placebo injections. In 084, there were no discontinuations due to injection site reactions. 21% participants had any ICR, and 4% participants had grade 2 or over ICRs. The odds of discontinuation CAB were strongly associated with the severity of the injection site reaction. Now, moving to adverse events in general, CAB-LA and TDF were well tolerated, with most AEs being mild or moderate in intensity and balanced between groups. CAB-LA for PrEP had comparable safety and tolerability to TDF-FTC in MSM, transgender women, and cisgender women. In summary, HPTN-083 and HPTN-084 showed a 66 and 88% reductions in HIV infections in the CAB-LA arm compared to TDF-FTC among MSM and trans women and cisgender women, respectively. Both trials were unblinded early, as CAB-LA demonstrated to be effective in preventing HIV compared to oral daily PrEP. CAB-LA likely conferring an adherence advantage. A protocol amendment was issued, as I said, to offer open-label CAB-LA and also to include adolescents an option to make the oral lead-in period optional, to include RNA testing in all visits, and importantly, to relax the contraceptive requirements besides the option to consent for active dosing through pregnancy. Data from both HPTN-083 and 084 led to FDA approval of CAB-LA for HIV prevention in December 2021. Now we will move to some of the challenges that we face ahead when we think about implementation of CAB-LA. CAB, as a long-acting drug, can make HIV diagnosis challenging if HIV infection is not diagnosed before CAB initiation. CAB-LA suppresses viral replication and delays antibody production. As such, the rapid tests and antigen antibody assays often fail to detect infection. Supplemental antibody tests may be negative or indeterminate for many months, and HIV RNA levels often remain low or may be undetectable for long periods. This delayed detection of HIV infection may then lead to delayed ART initiation and the emergence of integrase resistance, and we will dive a bit in on that. The HIV infections observed in HPTN-083 were classified according to the timing that they occurred. Overall, there were 4 infections, and now you pay attention on the groups that I will point out. So group A are those infections that occurred prior to the administration of CAB-LA, and those are prevalent infections, HIV infections that were there but were not identified prior to an injection. The group B were those infections that were diagnosed with more than 6 months after the last CAB injection. There is another group called BR, that these same individuals were more than 6 months without receiving a CAB injection, but were exposed to a new injection and were already infected. So this BR group is almost similar to the group A. The group C are those individuals who got infected during the oral lead-in period. There is now an optional period according to the FDA approval of this drug. The group D of infections are those infections that are called the two breakthrough infections that occurred during on-time injections, and those are the most preoccupying ones. And the DX group is with almost on-time injections, but they were a bit delayed with at least a 10-week delay, at least for one of the injections. And the group E are for those infections that happen in the TDF-FTC group. So while CAB-LA has substantial beneficial effects in reducing the risk of HIV infection, there are concerns over possible risk of integrase inhibitor resistance with its use due to initiation in primary HIV infection. That means in an individual receiving an injection, being during acute infection, and not being diagnosed with HIV infection. The second reason is infections, breakthrough infections while on CAB-LA, and infections that happen during the CAB-LA period. And we will talk a little bit about each of these situations. As we consider the totality of the data from HPTN-083 with regards to the selection of integrase resistance, we have found very helpful to consider the risk of integrase resistance with CAB exposure in the different contexts that we just mentioned, the different groups. It is better, we think it's better for us to explain this resistance than in aggregate, as was done in a recently published meta-analysis. So if you look again, a total of 2 of 6 or 33% of cases in which CAB-LA was initiated or reinitiated in a setting of occult HIV infection developed INSTI-associated mutations. 2 out of 3 individuals who acquired HIV during the oral lead-in phase developed major INSTI resistance associated mutations. All of the breakthrough infections in the setting of on-time injections, but none of the breakthrough infections in the setting of a 10 or more week delay had major INSTI resistance associated mutations. And very importantly, interrogating the so-called tail phase infections, none of the now 16 infections at least 6 months after the CAB-LA, the last CAB-LA injection, had major INSTI resistance mutations. So there was a lot of fear about the potential of emerging integrase mutation in the setting of the tail of the CAB-LA. And we couldn't find any integrase mutation so far in individuals from that group. Regarding the HIV infections in the TDF-FTC study are non-optimal adherence was the overwhelming explanation for those breakthrough cases. And when we go to HPTN-084, HIV infection was confirmed, as I said, in 4 CAB arm participants, including 1 who was found to have HIV infection at enrollment prior to CAB administration, which was reclassified as a baseline infection. 2 participants with incident infection received no CAB injections whatsoever and had no recent CAB exposure. And the 3rd incident infection occurred during the injection phase of the study in a participant with delayed injection visits. So CAB-LA has substantial benefit effects in reducing the risk of HIV acquisition. Concerns remain over possible risk of integrase inhibitor drug resistance with use of CAB-LA due to initiation in primary HIV infection and infection breakthroughs while on CAB-LA. These breakthrough infections are very rare, but so far remain unexplained. HPTN-083 now reports a total of 6 cases of breakthrough infections despite on-time injections in 4,660 person years of CAB-LA follow-up. HPTN-084 identified, as I said, very few infections and no true breakthrough cases. Importantly, no integrase resistance was detected in any of the cases in HPTN-084. So what we learned so far. CAB can make HIV diagnosis challenging if HIV infection is not diagnosed before CAB initiation. So if it happens during acute or the eclipse phase infection, or meaning very early infection. HIV rapid tests and fourth and fifth generation lab tests were delayed in turning reactive and would flicker. Failure to diagnose HIV infection at injectable CAB-LA initiation can lead to continued CAB-LA administration. Viral escape at high CAB levels can lead to CAB and other integrase resistance. And the oral lead-in is optional, according to the FDA package insert, making those infections, as we saw the group C infections acquired during the lead-in period, not something that we really need to be worried anymore, if we opt not to provide the oral lead-in phase that is optional. CAB-LA breakthrough infections, as I said, remain very rare, but remain unexplained. HPTN-083, as I said, now reports 6 cases. And as I said, these reasons are unclear. Possible explanations, although we really don't know the correct explanation, may include the comparatively lower tissue drug levels in the rectum as compared to the plasma levels. CAB partitions in rectal tissue are 8 to 10% of plasma concentrations, as opposed to 20% when you talk about the genital mucosa in women, the vaginal, cervical-vaginal mucosa. Inflammations related to rectal STIs may also be, in part, in charge of those breakthrough infections, large exposure in inocula, or other factors that we truly don't know yet. As I said, the pharmacological tail of injectable CAB was often cited as an additional concern, as you may remember, in the phase 2 HPTN-077 study, 13% of cisgender male and 42% of cisgender females had detectable CAB concentrations 76 weeks following the last injection. Very reassuringly, in HPTN-083, there was no evidence of integrase resistance in any of the individuals who were diagnosed with incident HIV infection during the tail phase. And of course, additional data from the open label phases of 083 and 084, and also from the real world cohorts, will be needed to confirm that significant integrase inhibitor resistance does not occur during HIV acquisition during the CAB tail phase. So, due to these concerns, some may argue that having molecular HIV testing availability is a requirement to implement CAB. By adopting such cases, we may identify a few people early, with some starting ART early and preventing, therefore, drug resistance. On the other hand, requiring molecular testing will delay PrEP initiation, as well as induce a complex lab-based algorithm and decision-making to establish HIV infection if CAB is initiated prior to NET results. Finally, the introduction of molecular HIV testing will significantly increase cross-service delivery complexity, and therefore fewer people likely will access CAB-LA. So the possibility of having point-of-care NET may theoretically reduce the turnaround time, but this is not yet available. Very importantly, besides as you know, the FDA, the FDA required molecular testing for CAB-LA implementation in the US. The 2 other countries where there is already regulatory approvals, Australia and Zimbabwe, none of those countries have mentioned the need of molecular testing in their country regulatory approval. So that's a very interesting observation. We hope that HIV viral load technologies that are improving greatly in the most recent years will make a difference in the use of CAB-LA in the future. Of note, it's important to say that none of the individuals that seroconverted in OA3 were started on an integrase-based ART. So there is no experience so far with that. As individuals were located in different settings, those in the US initiated a PI-based regimen in most of the low and middle income countries participating in the study, and a efavirenz-based regimen was used. So we don't have the experience of initiating an INSTI-based ART regimen yet. So there are some lessons learned. So up to now, both CAB and TDF-FTC are highly effective for HIV prevention. CAB-LA was shown superior both to MSM trans women and cis women. The increased incidence in both arms in OA3 may be attributable to attenuation of adherence persistence and increased contribution of high incidence regions, as I mentioned it. CAB-LA breakthrough infections remain very rare, but yet unexplained. And we already talked about the importance of the INSTI resistance seen when viremic escape occur at high levels of CAB concentration. I'm sorry. In HPTN-084, CAB continues to be superior to TDF-FTC in preventing HIV infection in individuals assigned female at birth, with an 89 lower risk of HIV in CAB versus TDF-FTC, no new safety concerns identified. Importantly, pregnancy incidence increased in the unblinded period and confirms the high importance of evaluating CAB safety and PK in pregnancy during the HPTN open-label extension. And CAB access should be a priority for populations at the greatest needs. Again, very importantly, despite increases in integrase inhibitor resistance, it's likely that the benefits in terms of reduction in AIDS-related mortality due to CAB-LA will outweigh the risks. And these are results from work already published from Andrew Philip and his group done in South Africa. It's important that immediately linkage to care and ART optimization for all individuals diagnosed as living with HIV, it's really critical. And also it's critical to have surveillance for integrase resistance and subsequent response to integrase-based ART should be performed during CAB-LA PrEP rollout for further informed policy. So as I said, approvals were granted now in 3 countries, the US, Australia, and now Zimbabwe. And we all know that there are historically the introduction of evidence-based technologies into public health programs have been fraught with delays resulting in missed opportunities. And these are related to several factors such as delays in registration in low and middle income countries, preparatory evidence that is not in place, and importantly, the expansion of the HIV prevention options need to be done while expanding PrEP coverage entirely, ensuring that the introduction of a new PrEP modality increases access and reduces disparities in PrEP uptake, rather than simply providing alternatives for individuals already engaged in PrEP. And this is a major challenge. The rapid development of implementation science to guide the large-scale adoption of long-acting PrEP will be vitally important to understand the outstanding issues and implementation approaches for populations who urgently need effective prevention choices. I just wanted to check how many minutes I have so that I can organize here.
Probably just about 5 minutes, Beatriz, if you can wrap it up in 5 minutes. Do you think you can do that?
I can try. So I will run a bit. So these are some of the implementation studies that are planned in several parts of the world. As I said, we greatly need these implementation studies to happen. These studies need to have the person at the core of person-centered HIV prevention is the importance that people are best placed to decide which prevention methods are right for them, and that their preference may change over the course of their life. So HIV prevention is not only on individuals, but for and with them. And it's also central that people have the capacity of having the good understanding of what is available, the advantages and the disadvantages of the available methods, and information enough for them to have an informed decision-making process. So I was just going to move to some of the preparatory work that we have done in Latin America. So we have done surveys to identify the knowledge that people have on other PrEP choices in Latin America. We did in 2018, we found that 42% already had interest in injectable PrEP. And in 2021, we repeated this survey that with almost 20,000 individuals. And at that point, 75% would be interested in using an injectable PrEP option. I just wanted to share with you that here in Brazil, we will implement, we will do an implementation study. And this implementation study is called the CAB Brazil study. It will be a study to generate, the main goal is to generate critical evidence to inform the national policies and program implementers about optimizing the delivery of CAB-LA for MSM, non-binary and trans individuals within public health PrEP services in Brazil, as these are the most affected populations in our country, and also to assess facilitators and barriers to integrating CAB-LA into existing public clinic health services in Brazil. And also a clinical objective to evaluate the effectiveness of CAB-LA PrEP at reducing risk of HIV acquisition in this cohort of individuals. We will enroll, there are several secondary objectives. We will enroll 1,200 MSM and trans individuals aged 18 to 30 years of age, all of them PrEP naive. And this will happen in 6 PrEP public health services in 6 Brazilian cities. So we are already doing preparatory work, focus group discussions with providers, with potential users. We will have an mHealth education instrument that is being developed and adapted with focus groups to discuss this instrument as well. And we will also have WhatsApp messages, reminders for the injection visits. Very briefly, individuals will who are coming to PrEP oral PrEP services, because in Brazil PrEP is a public health policy. Individuals who are coming for PrEP will be offered this opportunity to enroll in this first phase of the study, where they will receive education using an mHealth instrument or standard of care. So this is the first stage of the implementation part of the study. And if they choose to go into CAB-LA, we will have a second stage in the same day, where we will proceed with a gene expert test. So just to mention, in the first stage, they would have done the HIV rapid test. If negative, they will move ahead. And if they choose CAB-LA, they will have a gene expert with the same day result and same day initial injection if both the rapid test and the gene expert are negatives. And then they will be randomized to receive or not receive WhatsApp reminders. So just to try to wrap up, As you know, in this map, there are regulatory submissions were already done in several parts of the world. This is just the beginning. We hope that these submissions expand very fastly. And you may also know that there was an agreement with the Medicines Patent Pool to develop a generic. We unfortunately don't expect that this will be available, a generic version of Cabenuva within the next 5 years, but we remain hopeful that it will happen. This in blue, you see the territory licensed to produce generic, and we hope that this can highly affect the prices that we will see with Cabenuva in the future, as this may be definitely a major hurdle for us to expand cabotegravir MA. And just to finalize, long-acting PrEP agents may overcome current PrEP challenges with PrEP persistence. With additional experience, CAB efficacy advantage persisted. Cabenuva is undergoing regulatory reviews, as we know. And as you all know, inequalities are a major driver of the HIV epidemic, which continues to disproportionately burden the most vulnerable, despite the availability of effective prevention and therapeutic interventions. Our current models of HIV prevention delivery are not at all responding to the needs of these populations. Stigma and discrimination remain as significant roadblocks. The interplay of different forms of discrimination go beyond homophobia and transphobia to include race, ethnicity, and social class. All these forms of discrimination, coupled with HIV-related stigma, significantly hinder access to health services as they are reproduced in the HIV discourse, media representations, and society at large. The gaps in HIV response and resulting HIV infections and AIDS-related deaths lie upon faultiness and inequalities. The most vulnerable populations struggling with poverty and social inequalities are the ones that suffer the most from HIV. We just hope that long-acting PrEP does not deepen the already profound inequalities. On the contrary, we hope that it may be a step forward in our efforts against the inequalities. The structural violence approach allows us to reconceptualize health discrimination and understand the root causes of illness, not merely as a result of stigma or prejudice, but as a consequence of fundamentally unequal social and economic structures.